Welcome to CGT Square Talk, where top experts in the industry share their groundbreaking journeys. Brought to you by Blue Squared, your strategic digital partner.
Hey, Greg.
Hello.
How are you doing?
Good. How are you, Anthony?
I am well. I'm well. Hey, Greg, I don't know if you've met Armen or not. This is Armen Gasanyan. He is our head of customer success in the Americas.
Hi, Greg.
You guys have a little bit in common. You're both certified Scrum Masters.
I think my certification has lapsed, but yes, I did go through the process.
Well.
It is nice to meet you.
Nice to meet you.
Well, thank you for joining our podcast. I thought maybe a good way to start, I'd love to kind of get a sense of your journey that you've taken. You've had a really interesting career, right? You started as a systems person, and you built training applications. You did some interactive games for kids, and then you actually worked at a very large retailer up in the Minneapolis area.
Yeah.
Their Target.com and all of that. And how did you get from there to where you are now, kind of account management for? Is it okay if I mention the name?
Yeah. I don't.
NMDP.
Yes.
Yeah. So.
Yep. So I actually started out as freelance business writer. And so I was doing writing for that. And then as multimedia came up in the 90s, CD-ROMs and all that, I started writing scripts for multimedia. And then there was a video production company that wanted to get into multimedia. And so they said, hey, can you help figure all this out? So we had a small team, and we figured everything out from scratch almost. The programming, the digitization of video and audio, graphics, animation, everything.
That's pretty cool.
And it was a challenge to make things play smoothly, and it was very interesting. And then, of course, the web came along, and I pushed to get into that, and then really got interested in the programming piece of it. Yeah, I did training programs for people or for companies, and then moved into more of the deep data-driven website development, the three-tier architecture, and that eventually got me to the national retailer. I worked on their pharmacy site. I worked on healthcare sites along with some other things, and then was selected to work on an expansion to a country to the north that didn't quite go as well as we planned. And so I was looking for work in the middle of 2015, and one of my network of people said, hey, there's this back then it was Be the Match was kind of the more common name that people knew. There's this opportunity here to help with a technology problem or technology project there, program really. And I said, okay, yeah, because I was looking for something that was had a social impact, right? And you can't really be saving lives through
exactly.
leukemia and lymphoma and other indications. So I went there, and I just came in. It was too early. They brought me in too early. It turned out to be about a year too early, actually. And so my boss just said, hey, there's this new business development thing that started up. Can you just go see what you can do there? And it was just this great opportunity for a career change. They needed somebody who knew how to, estimate costs of things, do proposals, and work with clients and do contracting. And these are all things I had done. So it just worked out really, really well for me. What I didn't know, of course, was the science and the biology behind it, which I've had to learn. And of course, that's just an endless.
Oh my God! Tell me about
it.
Tell me about
never
it.
stops. Yes.
Yeah, the people in this industry, the medical and scientific people, are amazing, and they learn more than I could ever possibly keep up with. It's impossible. So, but I've done as much as I can to be able to talk intelligently to lay people. But I kind of listen when medical and scientific people are talking and try to learn more. So, yeah, I got into that, and then as we grew, so NMDP. 9 years ago, the leadership said, hey, there's this cell and gene therapy going on, and this really extends our capabilities. So NMDP is actually much older organization. It's about
right. 80s. Didn't they start around 1970 something?
I think is when they officially started in a small American Red Cross office in St. Paul. And it's really to find unrelated donors for stem cell transplants for patients with, again, leukemia and lymphoma are the two major indications. And so this is a very, very serious disease that's not, either relapse after chemotherapy or, didn't respond to chemotherapy. And so it's getting down the treatment cycle. And stem cell transplants are amazing when they work. They don't always work, just like any therapy. But it is challenging to find, manage a donor registry, find donors. But now we are networked in with a worldwide registry. Can get donors from all over the place. Started out with marrow that was taken from the iliac crest, with long needles. Then with some drug enhancements, they were able to get it from peripheral blood through apheresis, and then cord blood units came. So after the birth, the parents can donate their cord blood units to public banks for use in stem cell transplants.
So you started in 2015, and then in 2016 they launched the NMDP biotherapies,
yep.
right?
Yes.
So I'm imagining you were part of kind of developing some of the. Just tell me a little. That's kind of interesting.
Yeah.
Tell me a little bit about.
So a lot like when I said, the multimedia stuff, it was just a bunch of problems to solve, and that's just what I love to do. I just love to solve problems. So it was like trying to figure all this out. And again, it was close enough to what we did, and I had a lot of great subject matter experts who were brought in to help do that. But I was able to sort of manage that process of getting that already up and running in 4 months to be.
So from a technology perspective?
No, this was more process. The technology piece was to come because that was not something we had out of the gate. So it was more just the process of how you find it, identify the donor for this is for cell sourcing for off-the-shelf cell therapies. How do you identify the donor? Work up the
allogeneic cell donor. Okay.
That was one of our first clients that I really kind of kicked things off, and still a client today. And that's really the figuring out how to do that. All the regulations and quality pieces, those were all new, and so we had quality people brought in. We had collection network people, so we have apheresis networks, and all of that stuff was just how you do this under, cell and gene therapy as opposed to stem cell transplants is what are the differences? And there's just more highly regulated. It's more, because giving a donor cells to one patient is a lot different than taking donor cells and manufacturing it for dozens of patients or hundreds of patients, right? So they're just higher levels of regulation and oversight that we need. And so we had the quality people and put all that in place. And yeah, it was quite a challenge. And, we've continued to learn and continue to improve it. But yeah, I was part of kind of putting it all together, getting it out and starting doing the collections, and then starting to bring in other clients. So helping with the sales team with proposals and contracts.
So you were able to kind of pull that together, it looks like in about a year.
Yeah. We actually, our first client, we were talking to them before January, but January, when we kicked off officially the subsidiary, it was 4 months until actually 3 months because we started at the beginning of April, started collecting. So,
oh wow, that's short.
Yeah, it was a lot of good people utilizing the knowledge they had and understanding what was different about it.
I have an interesting follow-up question. This is actually very interesting to me in terms of the allogeneic versus autologous therapies, and in your professional opinion, right? So, is the industry focusing towards allogeneic versus autologous therapies because of the the reasoning behind it, right? It's too long, too expensive, and so forth.
Yeah, I think so. I think it's it has its own set of challenges. We've seen that to move into allo, but certainly the ability to do that is important. So one of the things with NMDP is it's a nonprofit. So, we are mission driven. We don't have revenue goals. We have lives goals. So we did like 7,000 collections last fiscal year for us. Do about 700 a month is where we're at right now. So it is.
Is that on the allo side?
Yeah, that's all. That's mostly stem cell transplants. Directly, but is a growing number of allo cell sourcing. And we support auto as well. So there's a few of those and some of those in there as well. But it is, I think the industry wants to move to allo because it just makes a lot of sense. And certainly in some cases, we'll see with hopefully Evalo getting its BLA approval, publicly known, we work with Atara. That will be a big step. But I think the industry would like to move there. It's just, it does have its own set of challenges that just need to be figured out.
Yeah.
Very interesting. And from the social aspect as well, it's very interesting how a lot of people don't think about it in this way, but from the social side of it, we want to do good in our society. And technically, how many lives do you think one person or one donation, one person can definitely help multiple people by donating their their cells. And what's that ratio? And like
Yeah.
for people to feel good, also internally feel good, right?
Yeah. I mean, that is the interesting part, and that's one of the things we can do. So most people who sign up for NMDP registry don't sign up for this. They sign up for a single patient, but a lot of them, we have had teams reach out to them and say, hey, would you be interested in cell gene therapy where you could help multiple patients? And they do that. The ratio is all over the place. It depends who you talk to, what time of day you talk to them. It could be one donation can do hundreds or thousands, or it could do 20. It's all over the place, and because it has such a direct impact on the financial model. And of course, the startups need to be able to show to investors and venture capitalists and even potential acquisition people that they have a good financial model where this could make a lot of money, because auto has limits, right? It has limits on what you can do in manufacturing. It has limits on number of people, and it certainly has limits on who can pay for that therapy. It's very challenging.
How often can somebody donate, and how often do they?
Well, we've actually had some changes with that. So there's more. I forget the official number, but it used to be kind of limited for an unstimulated product. Stimulated product is 2 lifetime. That's it, because the drugs like filgrastim that cause stimulation, you don't want to put a donor through that. There are risks, always risks with every medical procedure. MNCA collections, which is by far the most common starting material that we collect for people, is there are a lot more that you can do with that. Now, how many will they do? Because all our donors are altruistic. We currently don't pay donors. We have that discussion quite regularly, because some clients are looking for, they like recallable donors. This industry is sort of plagued by the fact that we just don't know why something works. And so when you get something that works from a donor, the obvious thing is, I want that donor's material again. And so we have that, and we can do that. And, for us, 2 or 3 times is kind of it seems to be mostly what you can maybe get out of somebody. And then they're sort of like, I've done my part. So that's
kind of from the donor side.
Yeah.
Right? Like, okay,
I've been as altruistic as I really need to.
Yeah.
I've done my bit. And so
which they have been, right?
Yeah, absolutely.
That's a big thing.
I mean, it's one of these things where we have one of the best things we have are donor patient meets up, because they're kept anonymous. And for a year, they have to be kept anonymous. And then we can contact them and say, are you willing to meet your donor patient? So for NMDP, it's one of the highlights of our annual meeting is donors and patients meeting for the first time. And it's really awesome. It's Kleenex on the table kind of thing, right? Somebody's actually sponsored them one year, which I thought was brilliant. Because it will get you to see that. And, for us, and what I still haven't been able to manage is one donor to multiple patients, which I'd love to see. One donor meeting multiple patients that have benefited from their donation. But I think the compensation piece, which of course is compensating for time, not materials, which is little semantics, but I understand that is something we talk about. And I think if you do find a donor, and this is something we have some brilliant people looking into, is how you identify a good donor up front for a particular client, for a particular therapy. At that point, if you're going to start bringing them back, you have to. We know we'd have to consider compensation. To at least think about it. And it doesn't mean we will do it, but it's just something that we have to do, to consider. Just because, you can't have a donor keep coming back 5, 6, 7, 8 times every few months to donate without them wanting something.
Do the demographics change a little bit? Like the altruistic donors, are they like in a certain demographic group as opposed to ones who would want to be paid or be okay being paid?
I don't know that. I mean, overall, one of the big things for NMDP, and this is we have a class of things we call match allotherapy. So these are therapies that are one donor, one patient, but there's now a manufacturing step, which might be just expansion or some other manufacturing in there. The demographics is a very important thing. It's something that drives us. So we have a quality goal. As I said, we have life goals, we have an equality goal, because definitely the chances of finding a match on our registry for a Caucasian are very high. And then it goes down as you go, to minorities, it goes down to very low percentages. We actually have done some amazing work on mismatching, and specific mismatching with some very different post-collection treatments, where we've been able to change those numbers a lot in the stem cell transplants. But I do know in cell therapy that clients have talked about the FDA asking them specifically about how their treatment fits for demographics, right? And do that.
How talk a little bit about mismatching. How does that?
Yeah, so
What's that about?
I don't. Yeah, and like I said, I don't have the scientific background to understand it all, but it's just understanding that there are certain. So HLA is what you match on. That's how your body tells self from foreign, right? And so you have to match HLA to do a stem cell transplant. Same thing with an organ transplant. So when usually we like 8 of 8, go up to 10 of 10, which is ideal. 8 of 8 is enough. And then you start going down to 7 of 8, 6 of 8. We got nervous. We did figure out that 6 of 8, 5 of 8, if you do change the post-transplant, but you have to know which HLAs to mismatch on. And this is our chief medical officer and our team working with others have figured this out and really changed the dynamics of who can get a stem cell transplant and really democratized cell therapy from a stem cell transplant side, because that was a big issue and we've spent a lot of time and energy trying to improve that. But we're all getting more diverse, right? The pool is only getting more diverse as time goes by.
Right.
So finding matches is just getting harder and harder when you try to innovate matches. So a lot of people were on the registry that were basically a match to themselves and no one else. There was no one else to match them. So the mismatching is a really, really big step forward in stem cell transplant field.
I have a question from the patient side, possibly. How rigorous is the process for matching, or how long is the process? So if the patient, if one is very sick, if the patient is very sick and they are waiting for them every day, every hour counts, right? So is it hard to find a match for a specific person? I'm assuming it's not just finding a match, but also going through the manufacturing process and getting the actual therapy to the patient.
So stem cell sorry.
Go ahead.
Oh, I was going to say, so stem cell transplant differs in cell therapy. There is no manufacturing step. There might be some cell processing that's starting to, like CD34 isolation. There's some things that are happening with stem cell transplants. Really just think of them, we think of them as the original cell therapy, but there's no manufacturing step involved. But it can
that's a bone marrow transplant.
Yeah, just a straight bone marrow transplant. Yeah. And there is a lot of time. There can be a lot of time. You have to find the donors that match, of course, depending on the patient. That could be many hundreds, if not thousands, to 4, or like I said, 0. And so, but then contacting those donors, and then if getting them to agree, getting them to respond sometimes is a challenge, getting them to agree to go through the process. And then there's a whole set of infectious disease marker testing, physicals they have to go through. We have very health screening questions they have to answer, and any of that can disqualify them or make them ineligible to donate. And but we do focus on that a lot. So service is another one of our metrics, which is getting the transplant centers the donor material when they ask for it. And that's something we focus a lot of time and energy to improve on as well, because that's a big thing for the patients, because these patients don't have many options left at this point in time, and many of them are very sick.
Do you have similar time constraints on the allo side?
So yeah, I mean, it takes a while. It takes about the same amount of time to work up a donor and take it through the process to do an off-the-shelf allo collection as well.
But the patient isn't necessarily waiting like they are on the.
That's the value is you don't have that time constraint. One of the things I like to tell people to understand NMDP and really where we come from is patients are lymphodepleted, and then we collect the product. So that patient has to get that material. Their life is depending on getting that material. So we have an incredible group of logistics people and supply chain people called case managers who work to make sure that product gets there, and they can they're watching the globe for strikes, train strikes. They can work around that, volcanoes, natural disasters, whatever it is. They just have amazing stories of what they've done. And all of that has been, of course, brought into biotherapy. So that capability to understand, okay, we know something's wrong here. So we're going to change how this starting material gets shipped, because something's going on that's causing a problem.
So you've really been able to leverage your experience on the bone marrow transplant, all those logistics into the cell sphere. So maybe walk us through, when you are doing collection for allo. So biotech comes to you and says, hey, we need cells of this, of this type and for these characteristics. What's the timeline like? How does that work? Maybe that'll be interesting for people to hear and understand.
So yeah, it really depends on how specific a donor they're looking for. And some have very specific HLA requirements, which of course we are very well suited to do. Other people have screening steps. So we do our own screening, like I said, infectious disease marker testing, some others, other types of screenings, but then we take a sample and send it to the manufacturer. And then they come back and tell us yes or no to this donor proceeds. And some of those are, 50% chance of success, some are 1% chance of success, right? It all depends on the manufacturer's own screening, and they don't share that information of what they're actually looking for because they consider it proprietary, and we don't really ask. But it can differ very, a great deal of how many donors we need to go through to get you a collection. It can be a very, very straightforward process, or it can be very complicated, just depending on what they are looking for. And sometimes, again, we don't know what they're looking for. Sometimes they're looking for some very specific HLAs or phenotypes or different things like that. That we fortunately have about 8+ million people in the U.S. that we can tap into if we need to, and so we can reach out to a lot more people than anyone else can do.
So from the time they kind of contact you, what's that lead time like before it hits their manufacturing cycle?
So do you mean like when they first contact us to start setting up?
Yeah. So I call you up and say, hey, Greg, I need some cells. And, will they say, hey, I need them by Tuesday, or I need
No,
them,
it's months. I mean, we have just released what we call a standard Leukopak product, which is sort of saying, well, this is what it is. And if this works for you, we can do this very quickly. And that can be up to 4 weeks, as little as 4 weeks to get there. If you have much more complicated processes, it can take longer than that. It can take a month or two to get up and running and be ready to provide, or actually start providing cells to manufacturing for a client. So it kind of depends. Cord blood units, which I've seen an uptick in interest for starting materials, of course, can be delivered much faster because we work with all the public banks and have all their cord blood data, and we can work with them to say, here are the cells you need, and we can get them. Yeah, we can ship those out next week.
Yeah, that was my follow-up questions. Are there any relationship with banks that or the banks that you can pull from? Because I would assume that there's a bunch of them out there.
So there's private banks, which is where parents will donate to for storage for their own future use if their child needs it for any reason. And then there are public banks, which almost by definition means you're working with National Marrow Donor Program, or was the National Marrow NMDP, to aggregate that data together and make that available to transplant centers to find. And it's unfortunately as a stem cell transplant starting material, it's been declining for a few years, mostly because the cell counts are low, right? They're not, and so they try double cords that were very common, but were common to be requested, but not everybody had 2 cords that matched. So then so the public banks have been struggling, and some of them have been going out of business, and other people acquiring their inventory. But now we see an uptick in interest from the cell and gene therapy. And of course, other groups are getting into cord blood banking, which is interesting. So we have an alliance of some of these public banks to try and help them transition into providing materials for cell and gene therapy, which is really starting to move, I think, in a positive direction.
So you've got a lot of experience kind of in the field, and you've got a lot of reach and logistic capabilities, right? Because you've been around so long. So, you mentioned NMDP, and then you called it the National Marrow Donor Program.
Right.
And before you mentioned Be the Match. And let me just ask you to kind of maybe clarify a little bit, because there are 2 websites, and I know there's the BeTheMatch.org and NMDPBiotherapies.com. And
so there's a brand transition that's going on, and as you know, those are for organizations. I mean, we're a large nonprofit, right? I mean, we're not, we're pretty big entity. So it started as National Marrow Donor Program. That's still the legal name of the company. And then I don't remember, this was well before I got there, is they wanted to kind of create what my boss always refers to as sort of the retail brand for the registry, right? Because National Marrow Donor Program didn't mean anything. So to get people on the registry, they came up with Be the Match. And Be the Match worked for a while, and then everybody started thinking it was a dating site. So
That's
We
okay.
actually,
Yeah, right.
we have stories of people coming in for job interviews thinking we're a dating site.
In the
So
70s and
yeah,
80s, that
yeah.
wouldn't have been the case, right? When they
No.
started.
But then 90s and 2000s, suddenly it became more
Yeah.
like people thought it was a dating site. So we just recently, back in December, rebranded as NMDP. That's officially, and so then we rebranded as NMDP Biotherapies as a subsidiary of the parent company. And just working through all that. So yeah, there's a little bit of confusion on the websites and branding, and we're still working through all that transformation, because it is a challenge to get all that taken care of, and we've team working on that. But yes, so NMDP and NMDP Biotherapies are really the two names, and then one other is the CIBMTR, which is the Center for International Blood and Marrow Transplant Research, which is a collaboration we have with Medical College of Wisconsin, which is gets all the outcome data from stem cell transplants, and actually contracts with a lot of the major CAR T companies to take their outcome data and the 15-year follow-up that the FDA requires. A lot of people don't know the relationship between CIBMTR and NMDP, and so they come to us and say, "Hey, are you guys familiar with CIBMTR?" And we just kind of chuckle and say, "Yeah."
So do that a little slower. What's that other website?
So, well, it's the Center for International Blood and Marrow Transplant Research. It's a collaboration between NMDP and the Medical College of Wisconsin to basically facilitate data research, clinical trials. We have a clinical trial network that we use mostly for stem cell transplant related trials, but we have done some CAR T transplant or CAR T trials as well. So it's a whole group, sort of a group within there that works on that and focuses between the two organizations. So it's but it's really important, especially if you come from transplant. I mean, that's where outcomes data is where you can find data about about stem cell transplants. And like I said, now they're collecting all of the CAR T data for most of them.
So you guys work with a lot of CROs through that channel, I would assume, right?
Yeah, we work with CROs. We actually have our own CRO that works on some of these trials as well. So yeah, we get a lot of the data. Like I said, it's mandated that we get all stem cell transplant data. And then it was mandated that the companies follow up on the CAR T, so they started working with us to do that, because we had the system. Well, we had mostly system, but our leadership was very smart to expand it early on and make it available and ready to accept CAR T data. So it was a very, very smart decision on their part to do that.
Awesome. All right. Well, thanks. Because that clarification I think is definitely helpful. I think Armen touched on this, but so where do you see the most interest these days? I think you kind of touched on that, and then where do you see the trend heading for the therapies or the starting materials, or what are you seeing happening out there?
It is really interesting, because it sort of does go in these cycles. Like, we get a lot of requests for different things at different times, and they seem to cluster. And right now, the two things I would say that are big as a starting material is cord blood units, as well as healthy donors as well. The cord blood units are sort of becoming popular. And then, of course, for NK cells, that's a big one right now that we see a lot of people looking to try to move out of. There's still, a lot of requests from CAR Ts and TILs and those kind of things. But those are the new things we're seeing right now in terms of donor requests, client requests for the industry right now.
Where do you think things are headed? Do you think that?
Yeah, I wish I knew. I could do very well for myself if I knew where things were going.
True, but
I think autoimmune, obviously, is big right now, right? That's where a lot of lupus and MS is really the big place to go. I think solid tumors, I don't know. I mean, it's a big, difficult thing to get through, and certainly if the industry could crack that, then it would become huge. But autoimmune is kind of the next big thing to go, because blood cancers are, that's our world. And so sometimes we lose perspective of how small that is in comparison to other indications that have, millions of people, as opposed to, tens of thousands. So it is interesting, but I do think that's where the industry is going. But it's really, those things can change pretty quickly with some data, data, and just changes.
Yeah, things. I mean, that's the one thing about this space, is that because it is so young, and it's dynamic. It's changing. The science is changing. The goals are changing. Well, not necessarily the goals. The goals are to save patients' lives, obviously, but yeah, things change and you have to adapt quickly and all of that. On a sidebar note, so you said you started your career in kind of, doing gaming and, well, not necessarily doing gaming, but writing scripts and things like that. But it turns out you're also a lighting designer for the Woodbury Community Theater. You've been doing that for a while, right?
I was. I kind of ended, or kind of course, went on pause with COVID, and I haven't got back involved with it. But yeah, I've done lighting design for quite a few years for theater productions. I've probably done 30.
That's pretty cool. How'd you get into that?
Well, I started a little bit in high school. I kind of got involved in theater and did a little bit on stage, but realized quickly I much liked being behind the stage. And then a friend of my wife's family was directed a lot of plays. And so, my wife wanted to be in something. And so I decided, well, I might as well see what I can do. So I helped. I said, well, lighting, I've always done like photography and stuff like that. So lighting's always been kind of an interesting piece of me. So yeah, I've done that for years. I've lit a lot of things. My biggest thing was that we did Les Mis, which for a community theater doing a no dialogue play, a musical, is huge. And it was amazing. And it was the most moving thing. And I almost just quit after that because I said that I could never top this.
It was exhausting.
Oh, it was exhausting too. Yeah. But we had a phenomenal lead who played Jean Valjean, who had never been in a play, but he sang Les Mis just about every day. And his voice was perfect. And it was great. And it is amazing. The talent that is in the community is unbelievable. It's amazing how good some of these people are, and they have day jobs, and then they come in and you're like, oh wow, you can sing, you can dance, you can do scenery. So yeah, and Woodbury Community Theater has gone through some changes, and like I said, it's with COVID, it's sort of not quite the same. So I thought about getting back into maybe finding a different one that's a little closer to home too, because it was quite a drive. But yeah, it was a lot of fun. It really is a lot of fun to do, and lighting is just it's visually great to just sit there and watch it.
Sounds like you should get back into that.
Yeah, I do. I have thought very seriously of doing that, just because it was a lot of fun and a great break from everything.
From everything else, right?
Exactly. You just focus on this, and then you kind of come out.
It's so different too, right? It's a whole different world. Right. One of my daughters did musical theater for quite a while. And yeah, it's a whole different kind of space. Well, Gregg, hey, it's been great. I really appreciate you taking time to meet with us and chat with us and share some of your experiences. It's been really awesome.
Thank you very much.
And it's a lot of awesome things that your organization is actually doing.
Well, thank you. Yeah, I think so too. I think so too.
Yeah, for sure. All right. Well, have a good weekend, and I'm sure we'll talk soon. See you later.
Thank you.
Bye. Wow. Okay. I think Gregg was. I found that really interesting, actually.
Absolutely.
I know it's a little confusing, at least it was for me, between Be the Match and NMDP. I'm glad he kind of sorted that out. And yeah, I think
I get the confusion actually when he talks. It's actually really funny when he talked about people are thinking that it's a dating site as a
dating site.
I get the confusion.
Be the Match sounds like a dating site. Not quite, but anyway.
Yeah.
All right. Well, that was great. I really did like that one. I think it gave us an interesting perspective, especially I like connecting. I like what he's talked about when he was connecting the donors to the patients.
Right. Huge social impact. This is where the social impact comes in place. Right?
Yeah, so for sure.
Every one of us can save other people if you can.
Well, actually, my aunt went through this. She had a bone marrow transplant, but her sister's was the donor, so she didn't have to go through this. But yeah, it touches everybody.
Yep.
All right. Well, this was great. Have a great weekend, and I will see you for the next ones next week.
Yes.
All right.
Same. Bye.
See you later. Bye.
See you later.
Subscribe for more insights from leading CGT experts.